So good evening, everybody. Just like to welcome everyone to this Island Health Informational Forum. We thank you very much for attending this evening and hope that you find this useful. I would like to acknowledge that we are gathering, that Port McNeill and the Mount Waddington region is located on the traditional territory of the Kwakwaka'wakw. I would like to thank Island Health for agreeing to join us this evening in this informational panel. And I would like to also thank those who are in attendance online. I'd especially like to thank the Mount Waddington Regional Health Network for assisting us in facilitating this webinar, and in particular, Angela Smith, who is the Mount Waddington Regional Health Network Coordinator. So thank you very much, Angela. There were many questions tonight that were submitted, or through the week that were submitted to us, and some with similar themes. All the questions were passed along to Island Health in their entirety. So if you had a little prologue to your question, everything was passed to Island Health. However, tonight we have grouped similar questions and themes together, so you may not hear your question exactly as it was asked. This was in an effort to get answers to as many questions as possible, and we do have a lot to go through this evening. If you do not feel your questions were asked or it was missed, an email will be provided at the end of this meeting. So joining me this evening from the town of Port McNeill, I have Councillor Shelley Downey, Councillor Derek Cole, and also Councillor Ryan Mitchell. Thanks very much for joining tonight. I'm going to turn it over to Leslie Ducher to please begin introducing, or have your staff introduce yourselves. Thank you.
Thanks so much, Gabby. I'm pleased to be here, also calling in from the traditional territory of the Kwakwaka'wakw peoples. My name is Leslie Ducher, and I'm the Operations Director for Mount Waddington, Strathcona Corridor, and the Northern Gulf Islands. And I'm joined here by some colleagues who I will allow to introduce themselves. And Dean, would you like to start?
I'm not sure if Dean is in the room.
Okay, I'm going to move off to Max.
Yes, hi, good afternoon, everyone. Yeah, just to the host, I think that we have a few Island Health folks that perhaps are audience members versus panelists. So if you don't mind having a look to capture those individuals. My name is Max Yashuk. I'm the Executive Director with Island Health for the North Island area within operations. Today, I'm calling in from the unceded traditional territory of the Comox First Nation. And I work with Leslie, Dean, Nicole, and the Triad, and others to help support health service delivery and strategy within the Mount Waddington area, also the Campbell River Strathcona area, and the Comox Valley areas as well. And it's just a great pleasure to be here today. And just like to thank everybody for being able to invite us into this forum. As Island Health, we're quite excited to be part of this conversation.
So I'm just sending a note. I believe that our other colleagues, Dean Wilson, Ian Thompson, and Nat Pottage might not be in the room per se, and I'm not sure. Oh, I see Dean now. Dean, would you like to introduce yourself?
My name is Dean Wilson, and I'm the Manager of Indigenous Health for the Mount Waddington area, and I'm part of the Triad leadership along with Leslie and Dr. Nicole Bennett-Boudelier. I'm calling in from Gwadzi, Port Hardy, and I'm happy to be part of this discussion with everyone today.
Thank you, Dean, and we'll go to Ian and then to Nat.
Thanks very much, Leslie. My name is Dr. Ian Thompson. I'm calling in today from Victoria, from the traditional territories of the Lekwungen speaking peoples of the Songhees, Esquimalt, and Wasanic First Nations. I'm here today as the Executive Medical Director in Medical Affairs at Island Health, and I've also had an interim responsibility supporting North Island. Particularly happy to be here because my first job when I moved to Vancouver Island in 2014 was doing locums up in Port McNeill. in 2014, 2015. And great to see some familiar faces on the screen, and really happy to be able to join you this evening. Thank you.
Hello, everybody. I'm Nat Pottage, manager for BC Ambulance Service up in the North Island District, and joining you today from the traditional territories of the Namgis and Mamalalakula peoples.
Fantastic. Is that everybody, Leslie?
It is, Gabby. Thank you.
Okay, great. So I believe this evening, Island Health is going to lead us off with a little bit of a presentation. And so I'll turn that over again to you and your team.
Thank you. And I believe that Max is going to lead us through our slides, and he and Ian have kind of put some together. So thank you.
Yes, that's right. And we may also have James in the audience as well. To be able to bite it.
Oh, sorry about that. Is James Hansen there?
Okay, well, we see your comments there, James.
Here he is.
Okay, great.
Great, thank you. Sorry, that was a bit awkward. I was off in space somewhere, I think. Hello, everyone. My name is James Hansen. I'm the Vice President for Clinical Services with responsibility for the North Island, including the Mount Waddington region. And I'm calling in from the Qualicum beach area and the lands of the Qualicum First Nations, where I make my home. Happy to be here. Thank you.
Okay, excellent. May I have a thumbs up that you can see the slide? Okay, perfect, great. Okay, so yeah, I will walk through some slides just to provide some general information. And I will share the slide deck presentation with Ian. So again, quite excited to be able to speak on some of these pieces of information. So first of all, when we're referencing the Mount Waddington region, we also include components within the Strathcona area as well. When we think about the responsibility for service that the Triad has, it also includes components within the Strathcona area. Today, we will focus in more on the Mount Waddington area specifically as we talk about acute care services. I believe that's really what's been pulling us together to be able to have this discussion. When we look at the Mount Waddington area overall, we have a variety of different services that are provided to individuals in the area and also visitors to the area. We have approximately 300 employees. Our estimated annual expenditures are about $21 million on these services. We provide services within the community settings, within our acute care settings, and also our urgent care settings, and within our public health and mental health substance use areas as well. We also have a variety of locations within the Mount Waddington area. Not all locations are listed here, but you can see that not only are our services provided within patients' homes and in the community, they're also provided out of our acute care facilities, urgent care facilities, and our clinics. And we do this in partnership with community providers as well. And also to note that we also have long-term care facilities that are operated within the Mount Waddington area. And these are attached to two of our acute care sites. In the Mount Waddington area, we have 3 hospitals that are relatively close in proximity of each other and an urgent care center. For a large number of years now, we have been operating these hospitals under one hospital program that's under the leadership of the Triad most recently. One hospital program, but under multiple sites. This includes the urgent care center as well. And this has allowed us, as we've experienced in the past, fluctuations in staffing or an increase in acuity at specific sites, for us to be able to redistribute the services that we have available and also to be able to shift the staffing that we have available to be able to concentrate our staffing towards a specific site or a particular site. This is a very unique and significant benefit to the Mount Waddington community, as we have this model where we can support fluctuations in staffing and still be able to provide local services, emergency department services, and acute care services.
Thanks very much, Max. And one of the commonest questions I get asked these days is, how did we end up in the current state in terms of the supply of physicians? And so I'm just going to take a couple of minutes and give people some background and context, because I think it might be helpful for people to understand the current situation. I'm going to talk largely about physicians because that's the world I'm most familiar with, but also, other healthcare professionals as well. So in my case, I finished residency training in 1993, so almost 30 years ago, and started practice up in Northern Ontario, although circumstances have really been quite similar across Canada since then. And at that time in Ontario, the feeling in government was that there were too many doctors ordering too many tests, driving up the cost of healthcare, which of course is always a large part of the provincial budget. And so they brought in measures such as proposed restrictions in billing numbers for physicians. They reduced the number of students admitted into medical school each year and so on. And after a few years, people realized things were on the wrong track, and some of these changes were reversed. Medical school enrollments were increased back to their former levels and so on. Part of the challenge, though, is that these changes take a while to work their way through the system. Medical school training is usually 4 years, followed by 2 to 5 years of residency training, often additional subspecialty training after that. And so those changes made in the early 90s really started to show up in the system in the early 2000s. By that point in time, a number of other larger societal changes were in play. Early in my days in practice, I joined a very old school style physician named Keith Wilkes, who practiced in the same community for 25 years. He worked 5 long days a week in clinic, was on call for his patients, weekends and nights, every week of the year, apart from the few weeks that he took vacation. I remember him admitting to me once that he didn't even really know his kids when they were growing up. My first day in practice, he said something to me like, Ian, I don't take a lunch break. I just grab a snack between patients. And I felt kind of guilty saying to him, like, geez, I eat lunch every day. Like, I am going to take a brief break. So Keith had celiac disease. He didn't follow the appropriate diet, I think largely because of his purely sort of work-oriented lifestyle. In 2003, he was diagnosed with an aggressive cancer of the small intestine, brought about in part because of his poorly managed celiac. He passed away in 2005 at the age of 56, which has particular resonance for me because I'm turning 56 this year. And although he was a mentor to me, I clearly remember thinking I didn't want my life to emulate his. And I think that many other docs have come to similar conclusions over the last decade or two. Lots of docs want to organize their work-life balance differently than they did a generation or two ago, which I think means working hard, but probably not the same punishing hours of an earlier time. And at the same time, the practice of medicine has changed. Medical care has become vastly more complicated. Patients are often living longer with more complex health concerns. The paperwork demands are exponentially greater. And so it's become a different job. It's still a great job, but it's a different job. And so one of the ideas that people struggle to understand is, even though the supply of physicians has increased proportionately greater than the overall population, it's become more difficult to get access to a physician. And like I say, it's a combination of factors, but a large part of it is just the changing of the job over the years. I remember one of my older colleagues waxing nostalgic about the days when the hospital where he worked was run by 3 nuns. You asked them for, what you needed, and that was it. Those days are over, if they ever really did exist at all. And so we have to organize the physician workforce and the broader healthcare workforce differently. And changes are happening. We're looking at increasing the number of medical training positions, increasing the number of internationally trained medical graduates who can practice in Canada, looking at associate physicians who are doctors trained overseas who don't have a path to licensure in Canada, but would be able to work under supervision and so on. the challenge with all that is that that also takes time to work its way through the system. And so I think those solutions are going to provide great results in a few years' time. But at the moment, we're in a challenging place in healthcare. And how do we really address those needs now? And then there's one other factor that I don't want to dwell on, but I do want to take a moment to recognize its impact. The pandemic has been hard on all of us, particularly those of us in healthcare. We've had to adapt our work almost over restrictions and direction change. Many of us have lost loved ones. All of us have lost things that we valued, opportunities to connect with family, to have social interactions, to travel, and so on. And so in the aftermath of the pandemic, we also see lots of people in healthcare who are, leaving the professions or at least considering doing so. And so these are really some of the pressures the system's under. And as it shows on the slide here, these aren't unique to Island Health. I mean, these are similar throughout British Columbia, throughout Canada, and in fact, through much of the world. But I think it's important for people to realize a bit of that context. In terms of rural and remote areas, I think they're impacted to a greater degree because when one doctor or one nurse leaves Victoria, the system's got a bit more capacity overall in it. So the impact of that one provider leaving isn't as great. If that same situation happens in Port McNeill in a smaller community, the impact's far greater. One physician, one nurse leaving, and so that's also part of the reality that we have to contend. And again, this is for all workers in the healthcare system: physicians, nurses, lab and diagnostic imaging professionals, and so on. Max, perhaps you can move us to the next slide. So in the short term, we're looking at a number of things, as you can see on the slide here. $4 million in new operational investments, looking at increasing health professional support resources within each hospital, looking at what we can do to improve primary care resources, looking at increasing operational leadership and support. Perhaps we can go on to the next slide.
Oh, sorry.
No, that's okay. I wanted to take a minute because I thought we'd had a slide about diversions and emerge closures. Is that still a part of the deck or is that moved on?
I think we've moved that one to our responses.
Oh, okay. Then I'll be happy to stop talking and hand things back over to you, Max.
Okay, yeah, I'm sorry. I took that down by accident there. Okay, let me get back into it. Oh. You can see this okay? Sorry everyone, I ended up hitting the wrong button there. I think this is where we're going to be going next there. So as Ian was describing, not only has the way that our health professionals have been practicing have been changing over time, but the impacts of the pandemic have also had a tremendous impact on the healthcare workforce across BC, across rural and remote areas, other provinces nationally and internationally. Within Island Health, we have been able to see this and forecast this over the last year and a half as we see and hear from our healthcare providers the increased burden and the workload and the impact that has had on our overall human health resource teams. So to be able to invest in and support local service delivery within our rural and remote communities, especially within the Mount Waddington area, we have been actively investing in creating new programs, enhancing programs that are currently existing. And this has added up to $4 million in new operational investments. So here we mentioned earlier that the overall expenditures within the Mount Waddington area is about $21 million. So you can see that we've made a tremendous investment in being able to grow and sustain services the way they are within Mount Waddington. We've been able to increase health professionals and support resources within each of our hospitals So increase the number of nurses within our hospitals, but also the support teams around our nurses so that it can reduce some of the burden and workload that they have. We've also improved primary healthcare services and resources. In partnership with the regional hospital district, we were able to purchase a primary care facility and be able to launch an additional owned and operated primary care center within Port McNeill. And we've also increased our leadership services and our leadership supports that are on site within our programs. So to be able to have a better understanding and to listen to our care teams and our staff and our physicians and try to understand what it is that we can do to be able to improve their work experience, improve our efforts around retention of staff, and also to hear about ideas that we could implement to be able to improve recruitment services too. Moving into the future though, we know that there is an absolute need for a continued partnership with communities. We need to work together to continue to build on our shared strategies and investments. When we talk to our staff and we talk to those individuals and hear about the pieces that are preventing them from working full-time or are making it more challenging to be able to move into the community, we hear about the needs around supporting housing needs, childcare, an ability to enhance incentives for individuals, enhance recruitment activities and retention activities. And we've been implementing these and also working with municipal leaders and community leaders to look at better ways to be able to engage with the individuals that we have, but also to create different programs where we have individuals who are interested in living and working within the community in leadership positions or physicians or nurses and other providers to be able to really showcase the community in a real positive way and to be able to organize community events and meetings with individuals that could be part of their peer group and really try to wrap our resources around. And something that we need to do continuing as we continue to move forward as well in devising more robust recruitment and retention initiatives. A big piece on this is really working with community. Another really important support and resource is the resources that we're receiving through our agency staffing supports. So these are the nurses through our agency providers that will come and work within our site for a number of weeks or months to be able to provide supports, but then we'll return back to the communities that they live in. We've also recently developed and launched a new program within Island Health, where we've asked nurses from across the organization all over the island if they would be interested to be able to work up in Mount Waddington like a travel nurse or agency programs. And that initiative launched 2 months ago, and we've had over 100 expressions of interest of individuals outside of Mount Waddington that work for Island Health that have said, yeah, I'd really like to be able to try and see what remote work would look like or what rural and remote care is like, or to be able to live and work temporarily within the community. And of those over 100 expressions of interest, we have 24 individuals that are already going through training and support and are booking shifts to be able to work up in the region. And then of course our locum supports. Locums provide a really great service for the doctors that we have locally providing service. It provides respite support and support for individuals to be able to take vacation or be away from their clinic and know that there's going to be somebody that's there to support them. Also during our physician shortages that we've been experiencing over the last year, we really value the benefits that we've been able to receive from locum supports to be able to have physicians assigned to all of our hospitals so that our hospitals continue to function as acute care centers. So continuing to work on not only recruitment and retention and building on our initiatives and working with community to see what it is that we can do for the staff we have and to be able to attract new staff, but also supporting those individuals that are coming to visit the community and providing them with a real great experience while they're here so that they can tell their friends who choose to work in that type of environment or scenario to also come and be able to support the staff that we do have locally to be able to provide the services that we have within the Mount Waddington area. But, it's still going to be a little bit bumpy. Even though we've invested so many new dollars, we've created new programs, new levers, new ways to be able to recruit and support and enhance our services. The national scarcity and the international scarcity of healthcare providers is projected to be ongoing for a number of years. So what would the next year look like? The healthcare workforce challenges will continue, and we will continue to do our best to mitigate the impacts of that. Our major focus will be on improving staffing and sustaining service availability. Currently, we mentioned that we have hundreds of individuals that work up in the Mount Waddington area for Island Health, but within our acute care sites, for the positions that we have posted, we have about a 40% vacancy in those positions that are posted. So we really do rely on travel nurses and casual nurses that work within the Island Health system that have shown an interest to be able to work in Mount Waddington temporarily, to be able to help support us as we navigate through and recruit individuals to work within those vacant positions that we have. But as this continues to be a focus, we know that with illnesses and unforeseen events that happen in individuals' lives, there will still continue to be times where we have unforeseen situations where we don't have enough staff to have fully operational, fully robust services within all of our programs and our facilities. So there will continue to be ambulance diversions, and we'll talk about what the definitions of that are with some of the questions that were put forward to us in our responses to those in the next portion. And there may also continue to be emergency closures as well, emergency department closures as well. But we're doing everything we possibly can to ensure that all of our acute care sites are well funded and well supported, and the additional resources that we're putting forward are allowing us to be able to pull levers that we've never been able to pull before. Our biggest piece, though, and something that we've really welcomed and are quite thankful for our community leaders for their support over the last year and a half, is that we need to continue to build on this ongoing partnership and enhance our partnerships with the community so that we have a very positive community narrative within Mount Waddington. So as we attract new individuals to be able to consider living and working within the community embraces all those individuals, regardless of how they want to be able to work. And we work together to be able to showcase the communities for those individuals. So this next slide just talks a little bit about how to contact Island Health. We have a website where we publish all of our news. When we do have a public service announcement, we put that on our website as well. We have a concerns and complaints and compliments line. So if there are any comments specific to the quality of care that people are receiving, we have an email for that, and you can Google and find that on our external websites as well. And a real easy email address is just info@islandhealth.ca. Through this email address, we'll be able to receive any kind of questions that come in and be able to route those questions to the most appropriate individuals to be able to respond back as well. Okay. Thank you very much.
Thank you very much, Max and team. So at this point, we're going to be going to the questions that were submitted from people throughout the last few weeks. Time permitting, and I'm hoping that we will have time at the end, we'll be taking questions from attendees as well. You will see a little Q&A box down at the bottom of your screen, and if you can put your questions in there, our moderator, Angela, will be monitoring them, and she will be asking those questions at the end. So the first section that we're going into has to do with service reduction and diversions, and we'll all be taking turns as council, and I'll turn that over to Councillor Cole.
Thank you, Mayor Wickstrom. Can everyone hear me okay?
Yeah.
The first question from a citizen is, in the last 90 days, how many times has the Port McNeill Hospital been on diversion? And in the last 90 days, how many times has the Port McNeill Hospital had to close their ER? Thank you.
Yeah, no, thank you very much for the question. I'll respond to the first one. Also for our responses, Mayor Wickstrom and others, we're also sharing in our responses back as you're sharing your questions to us across the council as well. So in the last 90 days, Island Health, in partnership with ambulance services, in partnership with Nat's area, Port McNeill Hospital was on diversion 62 times. So I think it's important for us to talk about what diversions are, and I believe that's the next question there. Port McNeill Emergency Department had been on temporary closure only twice in this calendar year that we're in. Those 2 times were based on very short notice, unforeseen absences of healthcare professionals, where we've had to make the really difficult and challenging decision to close the emergency department to ensure that the other emergency departments fully functioning and open.
Thank you. So on that note, then, could you please explain what the difference is between reduction of services, diversions, and closures as it pertains to our local hospitals and emergency rooms?
Yeah, okay, thanks. I'll take this one on as well. So a temporary reduction of services takes place when there's not enough healthcare staff or physicians to ensure the ability to provide responsive, safe care within a particular care setting or within a particular care program. Within specialty programs and in rural and remote communities, this occurs primarily due to short notice of healthcare staff and physician absences. When it's long-term, like when we have individuals who have vacation booked, or we know that we have gaps in service through long-term, we have a greater ability to be able to find individuals to be able to fill in those areas. It's a short-term that's the most challenging for us to adapt to. Because of our challenges when it comes to our vacancy rate within our acute care settings. Short notice absences primarily occur, like I said, due to unforeseen and unscheduled personal situations, such as illness or family emergency. Ambulance, or like emergency health service diversions means that paramedic staff are contacted and guided to take patients to hospitals that are more appropriately staffed. This practice of diversions as well is a very common practice in other sectors across Canada as well, where you have multiple hospital networks. It's quite common as a business and clinical practice to divert to areas that are better staffed or better situated to be able to receive those individuals. Within the slides, we talked about how within the Mount Waddington area with the acute care structure and the acute care architecture, we have this ability to be able to divert and ensure that most appropriate staffing is available to provide the safest level of care possible. And that's why we do that. We definitely ensure that those individuals that are within our emergency departments, or those who visit our emergency departments, or those individuals who are in our acute care inpatient settings are able to see appropriate care.
Thanks, Matt. Max, there's great concern regarding our hospital closing. So just straight up, is it possible that the Port McNeill Hospital would be closing as an acute care facility, which is what we are today? Is there any likelihood we could be redesignated to urgent care or a long-term care facility?
There's absolutely no plans at all to close the Port McNeill Hospital, to redesignate the hospital as an urgent care center or otherwise. When we look at the amount of inpatient hospital spaces that we require within the Mount Waddington area, we don't have other spaces to be able to provide, those acute care services if Port McNeill was to close. So there's no plans at all to be able to do that. Where we do plan, and this is part of us being having the ability to try to foresee certain scenarios into the future, is we do have plans for those short-term scenarios that may occur, where we need to think about contingency planning of how we are going to redistribute our staff and redistribute our resources to be able to provide the safest level of care. And because of that planning, when we were closed within the Port McNeill Emergency Department, we were able to provide really great patient care through emergency services within Port Hardy. And we actually had some very complex patients during that time. So there's definitely conversations that happen around what we need to do in those emergency situations.
Okay, thank you.
Oh, Councillor Mitchell, you're on mute.
Here we go. My name is Ryan Mitchell, councillor for the town of Port McNeill. And the next question we have is from a resident who wants to know, do we see a time And we might have ER closures or diversions in all three hospitals. And what would that mean for the Mount Waddington region?
Yeah, we're really fortunate to have excellent care teams within Mount Waddington, very dynamic individuals within our physician programs and within our professional programs that are focused on being able to support a high level of local healthcare delivery and a local healthcare system. We don't anticipate a situation such as this to occur in the foreseeable future. In the event that there is a potential temporary nursing or physician shortage that would impact all three emergency departments, local teams and local care teams would do everything possible to keep our sites open and functioning so that there is local service delivery. And I see James has his hand raised there as well.
Yeah, maybe I'll just add, I think it's important to just clarify and be as transparent as we can. We've been attempting to hire, or what we call overhire, into several positions in the Mount Waddington regions. We have not been as successful as we would like. The 4 million that Max identified as investments, those are human beings, those are people that we're trying to plus up in staffing across the system. It's, as Max has pointed out, it's very challenging to lead in a scenario where it only takes one nurse or one LPN or one care aide or any sort of a provider to call in sick on an urgent need, and then we're down completely. We need to get to a point where our hospitals have more staffing that's required for any given day so that we can go down. That's the goal that we've been trying to get to. It's the support that we need and the community support, frankly, in attracting people to the communities. We've put the positions up, we've posted them, we've advertised, and we've yet to secure individuals in those roles. So I just want to say that on behalf of our team here, that this is a very challenging situation, and our goal during these diversions is to ensure we minimally have one site that can manage across the three communities to the best of our ability. Our goal is absolutely to plus up in staffing so that we can have the redundancy in the system to have short call sick time and not be on diversion. So that's what those investments are about. They're actual people that we're trying to get into the community.
Councillor Downey, I think you've got a question next.
Sorry, I just had somebody contact me and they want to join the meeting, so they were looking for a link. So this really just comes right back to the ER and ambulatory. Prior to diversions and the closing of ER departments, is there coordination with our ambulance service to ensure that ambulances are available if somebody does call 911? Because there's stories out there to say otherwise. So could you clarify what that process looks like?
Yeah, thank you very much for that question as well. Yeah, absolutely. It's integral that we work with our ambulance and paramedic partners to be able to talk about what diversion may look like and what their staffing challenges are as well, to be able to put together a robust plan to, again, ensure that optimal services are available based on the constraints that we're working under. Nat, I don't know if you wanted to jump in on this response at all as well.
I certainly can. What takes place when there is a notification of diversion is our dispatch center in Victoria for the ambulance service is notified, and myself as the area manager gets an email as well. And then depending on the level of diversion and where it's going, I know the question referenced Alert Bay, we'll make sure that we have sufficient staffing in place to cover off everything that we can. If it's going to involve Alert Bay, we make sure that the water taxi operator that we contract with knows that there's a high likelihood he's going to have some work that in that 12-hour period. And then we look at our ambulance staffing in the area and see if there's anything we can do to bolster it in that next 12-hour period to cover off what we know is going to be obviously extended transport times out of the community that has the diversion in place.
Just to clarify, the concern is would an ambulance, like how many ambulances are actually in the community to be available in the eventuality that the ER is shut down? Who makes sure that there is an appropriate number available on duty?
To be frank, the ambulance service is exceedingly short-staffed this day, in this day and age, and most of the time it's one.
Thank you.
And I've just asked Angela if there is a question that could be a follow-up that's similar that's coming in the chat. Maybe that could get layered in. I believe you messaged me on that, Angela.
Certainly, by all means. Thank you, everyone. I'm here off screen moderating right now. So the question from Sarah in the box is, how do you expect the ambulance service to be able to keep doing these diversions all the time when the paramedics are super short-handed by diverting into Port Hardy that leaves Port McNeill without paramedics? If there's a major emergency, we will be without paramedics in our town. Other hospitals that divert also have more paramedics working in the day. How are you going to ensure our town doesn't suffer due to hospital diversions and no paramedics available? Thank you.
I'm not sure who wants to answer that. And Nat, if you're talking, you're on mute. I can't see you, so.
For the ambulance service side of things, we're not. We don't have any more staff. There's not enough people. That's the short and sweet.
Go ahead, Councillor Mitchell.
This question from a resident: is the lab and X-ray in Port McNeill slated to be closed in the next year or in the next 5 years?
Yeah, I can jump in on this one. Yeah, another really excellent question where I think we can provide just a very clear answer for the community. So there's no plans at all to close lab or X-ray services within this year or the next 5 years. Patients should not see a change in what they currently have for access now. But when we look at the health human resource challenges that we're faced with, one of the areas that there is a major scarcity of healthcare workers is within the lab area. So our lab teams, in partnership with us and also through discussions with the community, are really looking at a variety of different ways to be able to support the current lab staff that we have, to be able to support the work that they have and increase their satisfaction with their roles, to work with the other care teams that we have within the Mount Waddington area to understand the stresses on our lab staff, so that we can reduce any unnecessary burden as we can to their workload. And of course, also recruiting recruiting lab staff to be able to live and work within the Mount Waddington area. You know, additional to that too, we're also looking at opportunities for lab staff through travel programs as well, through agencies and other services. But again, you know, our really big goal and focus is to be able to invest in the services we have and ensure that services are available locally for Mount Waddington residents and the visitors within the area. So there's no plans at all to close.
Yeah, I have a follow-up, which I'll rephrase just a little bit differently. If we were in a situation where people couldn't access labs in their community, what efforts would Island Health make to accommodate residents getting to another hospital, say Port Hardy for blood work and X-ray? Acknowledging that not everybody has a vehicle and some are coming from other islands as well.
Yeah, you know, I can definitely provide a high level response to that. I know that there's a lot of contingency planning around this scenario and others, and maybe something that we provide a written response back to the community on. But absolutely, you know, we have a variety of different means to be able to support individuals to be able to receive care. And we do understand that there's individuals that don't have a means of transport to be able to move across the communities outside of what's available through a shared service. So we would look at opportunities and options available to be able to provide those type of services where we can, to try to reduce the burden as much as we possibly can on individuals who are looking for lab services if perhaps those services are reduced. Ian, I see your hand up there.
Yeah, if I can just add to that, I think the other part of that plan is looking at what we can do to expand point of care testing. Certainly, last time I was working up in Alert Bay on Cormorant Island, there are a number of tests that can be provided after hours without having lab staff. It's not an ideal situation, but as a temporizing measure in emergency situations, it can be really useful. So I think all those things have to be looked at as well.
Okay, I think I'm next, if you guys can hear me. So yeah, another concern from a resident. This one's pretty specific. There are concerns with the confidentiality during admissions. When speaking to the remote admissions clerk, people are in full view and hearing of the ER waiting room. Is there a manner to admit people so that they are not in plain sight of their neighbors and or public?
Hi, I'll start with this one and then see if Dean has anything to weigh in. Thank you so much, Councillor Cole, for the question. So I'm sure everybody is fully aware how important patient confidentiality is to us in providing care in all island health settings. And of course, I'm sure you're also aware that in smaller communities, there are additional layers to maintaining patient confidentiality. We do work with our teams regularly on ways of optimizing patient confidentiality. We also, during our interviews, we address the importance of patient confidentiality, and we do scenario-based questions, exactly describing what you've described. I think the other thing that we've started to do is map patient pathways through our facilities and through the different program areas. And through that, I think there's an opportunity for us to potentially look at opportunities to increase settings where confidentiality or higher levels of confidentiality can be maintained. Of course, I don't think it's also a surprise to anyone on this call that the smaller the setting, the harder it is to rejig kind of the configurations. But I appreciate the question, and I'll just ask Dean if he has anything to add.
Nothing to add. I think that's a great answer, but I just want to say that we're also looking at some of these questions as opportunities for consultation and ideas as well from folks. So we'll be taking away some of these ideas to continue working on things. So confidentiality is going to be added to that list. So thank you very much.
And I think there might be a follow-up question there, Councillor Cole, for you.
Sure. Thank you, Mayor Wickstrom. I guess back to the admission, how reliable has been filling the vacant admission, or there are vacant admission positions? Is that staffing a problem with admission?
So I think I could say that universally staffing most of our positions is a problem, or not a problem, a challenge, I guess. And some of them are harder than others, and that would probably be our clinical and lab staff. But all of our positions we prioritize. And one of the things that we've started to do is to look at a kit, if you will, a toolbox of rural postings, acknowledging that sometimes you're not going to get a clerk that has the specialty clerk education, but is there someone available who has a good knowledge base and could be actually trained to have the skills on the job? So I think that one of some of those strategies, building rural job descriptions and actually having processes that support the context and the reality of living in a smaller community, are one way that we can continue to keep our admission clerk positions full, which I have to tell you, I don't have that number right on me, but I would suspect is a much fuller set of positions than our clinical ones.
Thank you.
Just and still in the theme of labs, is lab work being centralized to the Port Hardy Hospital or the Campbell River Hospital at this time?
Yeah, thanks very much for that question too. So outpatient lab collection hours are not changing in Port McNeill or Port Hardy. Island Health Laboratories have been operated under a central model. And that central model has been in operation for a number of years, many, many years. where samples are transported from our satellite sites and stations to larger laboratories and facilities for testing. We do have a robust courier system in place and examine routes regularly to ensure samples are tested in appropriate time frames and to also maintain specimen integrity. So for the patient experience and for the outpatient lab collection, we don't have any changes that we're planning or proposing.
Okay, and there's another question here from the public. It says, will there be a traveling phlebotomist if that is the case, if you are looking at centralizing those?
Yeah, so we're not looking at any type of centralization.
Not relevant.
Okay, thank you. So that was operations. We're moving on to staffing and attraction. So when doctors and nurses resign, do they give specific reasons in their resignation letters, or are they given exit interviews?
Yeah, so I'll share some of this response perhaps with Ian, or Ian, feel free to be able to jump in on the physician side of things. For physicians, letter of resignations are required, as these trigger various administrative processes to ensure that privileging is correct, and if there's removals to privileging, that those occur. Same with computer access and other components. Generally, physicians do not provide a formal reason for their departure, but we do have exit interviews where we can with our physicians to be able to understand a little bit more. And that's a process that is provided under the triad leadership model. And I also have been involved in exit interviews as well to be able to identify, any kind of information that we could consider as we develop our plans for retention and recruitment. When we have had opportunities to speak with departing medical staff, those reasons that we do hear around why individuals are deciding to leave the community, the majority of the time, or the real primary reasons related to personal reasons or family-based decisions. But of course, we also hear about opportunities to improve our services or improve the way that we have our structure set up for physicians, and we really listen to those. Ian, did you want to jump in on that?
Yes, please. So I guess a couple of questions here, and I noticed there's one about pay and the questions that I'll answer as well. So in general, when physicians notify us they're leaving, we don't ask the reason why. We do exit interviews for medical leaders who are leaving. I have seen some surveys done of medical staff leaving, and it's interesting because the reasons are disproportionately around family issues, as Max alluded to. Their partners can't find work, or their partners have come up with an opportunity somewhere else. They have aging parents on, either they or their partner that they're moving to be closer to, and all the rest. The question of pay is an interesting one because in a fee-for-service environment, I mean, the amount you make is dependent on basically the number of patients you see. And so, in a busy fee-for-service practice, you'll make as much money as if you're coming in and doing a locum. Locums typically, when they come to a community like Port McNeill, they're not paid for fee-for-service. They're given a daily stipend through the rural locum program. And then there's a variety of sort of incentivization programs for physicians in rural areas. So for instance, the fee-for-service billings for a visit in Victoria, I think an intermediate standard office visit pays just under $32. In Port McNeill, that same visit is paid a fee premium of an extra 22.82%. So there's an additional fee premium. There's also money in terms of relocation support, recruitment incentives. There's MOCAP, which is funding for on-call availability. There's rural emergency enhancement fees, continuing medical education fees, and all the rest. And so it's usually not money that's the determining factor in terms of someone leaving a smaller community. As I say, when you look at the various incentive programs that were put in place to attract physicians to rural communities, they're really quite well remunerated. The reason to leave is usually more around personal issues that people or their family members in many cases exploring opportunities elsewhere.
Before Councillor Goldgloster's question, I just have a follow-up comment, and that is if there's any type of comment that comes that is related specifically to us as a municipality, or something we can advocate for, if somebody's having problems with daycare, housing, whatever, it would be beneficial for us to be able to hear those. And one other quick thing our moderator just pointed out, if you could again specify for the public what the triad leadership model is.
Yeah, absolutely. Maybe Leslie and Dean, you could introduce the triad leadership model, and then I'll follow up to your comment there, Mayor Wickstrom.
Sure, I'll take a swing, and then Dean, you can jump in. So historically, I think in health leadership positions, there's been a dyad model where an operational leader and a physician leader forms a team that provides leadership to local programs and services. And one of the novel, wonderful, and innovative approaches that actually drew me to this area to work is the triad model, which is similar to a dyad model, but with the important addition of an Indigenous leader as well, acknowledging that a significant portion of our population is Indigenous and we have the large communities that we serve. I think that this is really an important model. So the three of us collaborate daily, kind of on which strategies we want to go forward with. And when the staff seem to need some on-site leadership, we make sure that the three of us are open to one of us being on site for visible leadership with the staff and addressing concerns and implementing and supporting changes as we go forward as a threesome, covering all of the major three groups of people that I think are leaning on us for leadership. I'll stop there, Dean.
And just to build on what you've shared, Leslie, thank you very much. In our local area, Indigenous communities have become major players in the delivery of health services. And we're in partnership around a lot of key initiatives and working to help actually fill some of the gaps that exist that actually benefit everybody with these partnerships. And so that's been a key expanding part of our role up here. And while we each have our own areas of expertise as part of the triad, we're involved in a collaborative decision-making process. So we work together quite closely. And our triad partner, Dr. Nicole Bennett-Boudelier, who of course is a physician out of Port Alice and sometimes provides backup support services in Port McNeill as well, isn't here with us tonight, but she's a key person in our triad. So I hope that helps to explain.
Yeah, thanks, Dean. I'll just mention that Dr. Bennett-Boudelier is actually doing a locum this weekend in Alert Bay, helping over there because there's a lot of people in Alert Bay this weekend.
Yes, excellent. Thank you, Dean. Thank you, Leslie, for introducing that triad model so well. Mayor Gabby, just to finish off on that question. So we did speak to what happens when physicians let us know that they're leaving practice or leaving the community. We also have a process in place where when one of our island health staff decide to leave the organization, they receive an exit survey that allows them to be able to provide information to us around their reasons for leaving. But also the local leadership team puts a concerted effort into having those exit interviews with staff. And also state interviews as well. So it's not just about asking after the fact, but also having those engagements and discussions with staff individually and as larger groups around what are the pieces that we could put in place to help support retention efforts or recruitment efforts, make the job a lot better or easier, those pieces. So those conversations are happening. Now, when it comes to that second question that was asked with the follow-up, we do have this goal and this focus to be able to work with community leaders to develop and reinforce new ways to support recruitment and retention for medical and healthcare staff. We've been working with various groups to be able to test and pilot different modes and mediums to be able to have those local leaders to be able to tour and show like what communities have to offer, what it would feel like to live and work within communities. What we are doing next within Island Health is we're very excited about this, is that we're in the process of developing a dedicated local recruitment and retention leader within the Mount Waddington area, who will have a primary focus on supporting and partnering with community to further create and implement more robust structures for these type of activities, to be able to partner with local businesses, nonprofit sector, the chambers perhaps, and really be able to have a dedicated focus around those type of efforts, as we are continuing to be committed to be able to support all the programs and services and facilities within the Mount Waddington region as well. So, as we continue to invest and create new positions and try to source new people in a variety of different ways to be able to provide services, we're also bringing these additional supports to help with that work. So it's not a job or a function that's secondary to a leader's function, but it's a primary function that we want to be able to bring into the community. So we're really quite excited about that. And that's where, when we have those exit interviews or those stay interviews, where we start to identify like the top 3 themes. Is it workload? Is it housing? Or is it something that we could perhaps co-develop with municipal partners? We want to bring those to various leadership committees and forums and be able to talk about opportunities to partner to be able to create those.
Excellent.
Thank you.
Yeah, Mayor, which of my, yeah, you guys can hear me. I think my question was pretty much covered by the last few comments. So in the interest of time, maybe we should move to Councillor Mitchell's comment. Thanks.
What creative, that would be question 11, right? What creative initiatives or specific incentives have been employed by Island Health to recruit doctors, nurses, and other health professionals in our area?
Yeah, I think we've been able to speak to a lot of those, but just to really reinforce, there are factors that are within our control that we're promoting to be able to help support recruitment and retention within Island Health and for the Mount Waddington area. We've recently, or actually not even recent, for the last 6 months, we've ran very robust recruitment campaigns nationally and internationally through social media and other forums to be able to advertise the opportunities that we have available within the Mount Waddington area to really be able to support recruitment or interest. And those have generated interest and also applications, which would then lead to Leslie and Dean and others to be able to engage with those individuals and then to have invitations to be able to come and visit. So we have been able to step up our ability and our efforts and intentions and our investments into trying to be able to recruit additional individuals outside of Island Health and outside of the province to be able to consider living and working within the Mount Waddington area. Ian, I see that your hand's up there.
Max, maybe before we go to Ian on the physician side, maybe I'll just add very, very quickly that we're not just looking outside of the organization. Island Health is a very large employer of about 25,000+ people. So what we are trying to do is attract folks that work in other areas into the region. So that is something within our control that we are attempting. And I think Max alluded to it earlier, but I think we had roughly about 100 people that were potentially interested. Absolutely, one of the barriers that we hear about is the availability of rentals in the community. So that is also something that we're exploring, and I believe have been able to secure rentals and some other leases or properties to try and support people that are interested in coming up. I did put in one of the chat responses that our goal actually is not to attract necessarily individuals that want to come up for a weekend, but we want people that want to come and work and live in the area for a substantive amount of time. So the plans that we have, the programs that we're developing, we're not going for short-term solutions. We're trying to get people very interested in living and working in the region. And maybe I'll just say one of the things that we're moving to is, rather than identifying sort of who we need in the healthcare system, what vacancies we have, whether it's a nurse or an LPN or a curator, whoever, lab tech, it's more about identifying who wants to live in the region regardless of their So I heard the other day of a young pharmacist, for example, who would love to live in Port McNeill. I don't know that we have a vacancy for a pharmacist, but my response would be, let's get them to the community because we could use them for healthcare in some way up there. So that's the sort of approach that I think we're going to have to start taking to attract people that want to live and work in this region, not necessarily trying to fill holes that come up as a result of people leaving. So I just think that's an important message. And I know some of the questions that are coming our way around bureaucracy and the speed to hire, that is absolutely a problem we're trying to wrestle down within our system. So I just want to assure folks that that is something that we're working on and we're tracking. We need to be in a position as an organization where if somebody wants to work, it's a handoff to a conversation, whether it's with Leslie or Dean or a recruiter, and then it's flying them out to see the community and all of those things right away. We can't allow, because of the market we're in, for there to be any gap in an application to basically to a warm conversation. So that is something that we're likely going to invest differently in the community. Leslie and I and Max and others have talked about what it would look like to actually have a recruiter embedded in the region. So that's something we're just trying to work out now.
Perhaps I can add a little bit, although James has covered some of the points I was thinking of. Many of the incentives for physicians are provincial, financial incentives and so on. We have emphasized, we have a physician recruitment team at Island Health, and their biggest priorities are primary care and psychiatry, and we have one assigned to the North Island. And what I've really encouraged her to do is, if she hears any interest, to direct that person to physicians currently in the communities. Because what we found both in Island Health and in Northern Ontario is that often that sort of physician to physician conversation is really the most sort of compelling recruitment tool, because people want to ask very specific, detailed questions about the nature of the practice and patients and all sorts of other things that often a doc currently working in the practice is probably best positioned to answer. And so we're going to continue emphasizing that as well.
Just want to note that we're at 7:37 and we're halfway through the questions. So is there an appetite for Island Health to stay on a little bit longer so we can get through these? Is that possible? I'm seeing some head nodding. Okay, great. So if we can keep that in mind when we're answering our questions. I love the detail, but thanks very much.
Thank you for the opportunity. The question we have here is presenting it. We do have nurses living in our region that have chosen to work as agency nurses and travel nurses. They've expressed a willingness to work in our local hospitals when they are at home. So the question is, are they being called in to support gaps in staffing? Is there an efficient process to allow this to happen? And who governs it, inside or outside the region?
Okay, I'll try to make it a little shorter this time. We have various avenues for nurses to express interest, same with other healthcare professionals or other professionals. Within Island Health, we have the expressions of interest that we have posted and various jobs we have posted. We suggest these individuals to either express interest that way or through our social media channels or directly to Leslie, Dean, or Nicole, or ourselves, or through the info line. Like there's no door is the wrong door. And as James said, we're continuing to build even more robust avenues for people to be able to express interest, or even, for more information or any of those other type of pieces. So we would absolutely want to hear from these individuals and work with them.
Okay, just for clarity, when we had our last ER closure, there was an agency nurse at home and did not receive a call. And so that's where the question comes from, is why would they not have received a call if we were so short-staffed? So something for you to dig into. I will carry on here. With regard to our nursing staff here, do we have many student nurses doing practicums in our region? And the basis for this really is it would allow them to get rural hospital experience, because my understanding is that currently they need to take additional training if they're going to come and work in a rural hospital.
Yep, so I'll jump in on that one. So I'll take it from the bottom, Councillor Downey, and yes, nurses that come through their program are ready for generalist practice, absolutely, but this type of rural nursing that happens here is quite specialized and they do require high level of emergency skills. So we do have student nurses doing practicums here, and we also hire employed nursing students. And both of those categories of learners have requirements on the amount of support that's available to them. So because they're either in a place where they're consolidating learning or they're actually just developing a baseline for their practice. And because our staff numbers are small and occasionally we have units staffed on agency staff, that doesn't necessarily fit with the model of consolidation of learning for the educational settings. And so, yes, but we have small numbers of them. So right now we have one new grad who did her final practicum with us, who's just started into a line. And this summer we actually have a employed nursing student coming up. One of the other challenges we have specifically that was just illuminated to me the other day when the employed nursing student reached out was the cost of living up here. So she wants to come and move. And of course, her salary is going to make pretty tight summer for her. And she'd like to save some money for going back to school in the fall. So I was actually probably going to reach out with some of my friends on council and say, is there something we could do to help this young woman to kind of get through the summer and not be broke at the end of it? Because I think, you know, a little bit of help with groceries or gas or something like that, I think is a wonderful way for us to partner and really show support for somebody that may end up being a long-term member of our community and contributing to the struggles that we're having.
Just for your information, we, as a pharmacy owner, to that pharmacist looking for a job, I know some pharmacies that are looking for staff. I understand recruitment and retention. So I think we're fine. Thank you.
Sorry, do you want to speak in before I ask the question?
Yeah, just the last question was around nursing students, but I just wanted to add that the rotations in Mount Waddington are really popular amongst medical students and residents, which is fantastic because that's really your pipeline for future docs. I know for myself, I did a month's elective in Churchill, Manitoba in third year, and it really kind of changed the path of my life. And so one of the things that, again, we're keen to continue promoting are those opportunities for rural experience, because there's lots of evidence out there that if you've only ever been trained in an urban center, you're unlikely to go to a rural center. It seems, you know, intimidating. You don't know what services are going to be available and all the rest. If you've had some training in a rural setting and you realize that the benefits there, the appeal of small town life, collegiality, and all the rest, the diversity of practice, the fact that you really become I think, a valued member of the community and all the rest. People, once they realize that, are far more likely to continue to practice there. And also in those rural sessions, they develop some, you know, important skills that are useful in future rural practice. So again, something we're really trying to encourage with medical learners.
Dean, you had your hand up. Did you want to add something there?
Yeah, just in related to learners in general, I just want to say we've also reached out to the education departments of our local Indigenous communities as well to explore community members that are in healthcare. And as a result of that, I'm happy to say we have 2 new referrals for support and learning. And the 3 most recent hirings that we've done have all been local community members as well, with a multi-generational history of staying in this area. So we're happy to see that kind of recruitment going on that we think is going to add to our stability.
Awesome. That leads straight into the question that I have, because this question comes out of the fact that it was alerted there were a couple of young people who wanted to return to our community and had applied and were somehow caught in this holding pen that is the application process of Island Health. So what have you done since our last meeting to ensure qualified nurses, specifically requesting our region, are given interviews and the opportunity to be employed here?
Thank you, Mayor Wickstrom. So following our last meeting, we actually were given the contact information and permission to contact one of those individuals who was a stellar note keeper and was able to really, she had documented every interaction with the organization and was really game to sit down and share her experience and share her frustrations. So we've done a couple things. We formed a working group that meets every Monday and talks recruitment and retention. It includes human resource, local managers, local clinical leads, and we've actually created a different kind of pipeline. So when names come in, we have a different kind of way of looking at them, as that was identified as one of our one of the challenges is she just couldn't get through. The other thing that we've been supported is in having a project manager who's actually just focused on recruitment and just actually building some processes and workflows for us so that no matter who shows up on Monday or who actually is in the pathway, if you will, everybody knows whose name is up and what your next job is. And then just to follow up on a point that either Max or James made, there's actually support from the organization to actually develop a rural recruitment and retention coordinator role. And we're just in the process of building that job description out right now. So actually the Mount Waddington area will be leading the way and actually creating a new kind of role, and we'll be able to test and see if that has a local impact. I don't know, Dean, if you have anything else to add on that.
Nope, you added the piece that I was going to point out about the coordinator position. So thank you.
Okay, I'll go next here. What is the long-term solution to secure more RNs? Isn't that the primary reason why our hospitals are on diversion? So I think you've spoke to a bunch of the short-term stuff you're doing, but maybe just a longer-term view.
Yeah, no, it's a great question, and a very like complex answer because there's no silver bullet. But when you can break it down, it's really twofold. One is retention of current staff and recruitment of new staff, right? Those are our two, both clinical and non-clinical. The way the questions pose is around RNs, but it's really being able to support a multidisciplinary environment and to be able to recruit into a multidisciplinary environment. And all those individuals that we're bringing in to work full scope practice and support services are all equally important to the function of our sites. We also know, many reports are now suggesting that the impact of the pandemic on healthcare providers is going to continue to grow and become an increasing burden nationally and internationally. So we need to continue to focus on how we can reduce the burden to our healthcare workforce and, in the long term, be able to protect them and their health as they work and provide care within all of our sites and programs. As a healthcare system and for our partners and communities, the immediate solutions are based on how we retain our staff with our healthcare staff as well. We want to be able to do this through achieving balance, flexible workload, affordable living. We want to be able to provide a really great culture and workforce. And we're making all those investments to be able to provide that and really create a place for staff that really want to be able to live and work and bring their friends over to live and work as well. In terms of recruitment, you've heard us talk about the national and international advertising campaign. We've learned a lot about our first run through that, and we have more plans and some really great new individuals with immense experience that have entered the organization that are going to help us in our development of our recruitment campaigns. We have the internal travel nurse program, the casual program that we launched. We have increased temporary housing support. So you heard James say that we've added more temporary housing. So we have housing available. We're trying to make that not be one of the limiting factors. So how can we introduce somebody and provide them temporary housing while they get sorted within the community and start looking for something a little bit more permanent? We're trying to provide those supports, and we're quite thankful to the community for having that availability provided to us as well. And also working to be able to coordinate with our agency staffing in a different way. So one of the things we haven't talked about is that we're really provided a great service to our agency providers. And the agency is now being utilized within a large variety of settings from urban and rural. So what we've been able to implement within Island Health, and I think it's one of the first of its kind in at least Western Canada, is now we triage or we assess our agency requests and we work with our agencies to ensure our highest priority areas are a highest priority focus for agencies. And we've actually seen some great uptake of agencies, staff working within our rural and remote areas, especially up in Mount Waddington. So These are just some of the pieces that we're trying to implement now and into the long term to be able to help support recruitment and retention.
Go ahead, Councillor Mitchell.
Yes, question 16, I think has been thoroughly answered in both parts. So I'll pass on that one and maybe somebody can do the next one.
Okay, I'll ask, do family physician fee structures for the province play a role in
Sorry, I'm happy to answer, Gabby. I think you went on mute sort of halfway through the question, so I'm afraid I
Sorry.
didn't hear it all.
I just realized that that's something wrong with my keyboard here. Do family physician fee structures for the province play a role in attracting or discouraging family physicians?
Yeah, it's a question with a lot of elements to it, and I guess in general terms, one of the challenges we face, and again, not just in British Columbia and other provinces as well, is that over the last number of years, to respond to sort of acute urgent needs, various things have been incentivized. So, we've seen incentivization of docs working in hospitals because there was a need for family docs to provide inpatient care. We've seen incentivization to work in UPCCs and all the rest. And so one of the challenges is that you put in those incentives to meet an urgent need, which is, totally appropriate. Over the longer term, what happens is you're relatively disincentivizing other things, and that's one of the sort of unintended consequences. And so, I think one can say that what's been sort of relatively disincentivized in British Columbia is longitudinal primary care. It's actually less of an issue in smaller communities, perhaps, than in larger communities, because in smaller communities, physicians typically still do a full service family practice. So, they're seeing patients in clinic, they're providing on-call services, often they're doing procedural things in the hospital and all the rest. The fee schedule, in and of itself is reasonably comparable across the country. I think for individual fee codes, Alberta and Ontario pay more than BC on a number of occasions. When you add in all the sort of rural incentive programs, some of which I alluded to earlier, though, for being on call and all the rest, the overall potential pay package is quite similar. The challenge is really around, in a system, are we incentivizing docs to become family physicians? And the answer to that, I think, in general terms, is no. And so you see that across the island and across the province. There's an attachment gap of something in the neighborhood of 1 million British Columbians don't have a primary care provider. 130,000 is the estimate I've heard for South Island and all the rest. So, primary care as a whole is certainly suffering, in part because, if you're in medical school and you hear about the current situation, I think that discourages a number of people from going into primary care. As I say, in some ways, the issue is less acute in smaller communities, but in fact, it's an issue everywhere. I'd be hard pressed to think of a community on the island at the moment that says, no, we've got plenty of family physicians, we're closed for business. So it's certainly a large issue throughout the health authority.
Thank you. I think Councillor Cole, you've got another question there.
Yeah, I think you've addressed some of this, but maybe the second part of the question. So what is Island Health doing to keep doctors here in Mount Waddington area and to ensure care is available when needed for our community members? And what is the messaging for patients struggling to get appointments?
Sure. Yeah. In terms of retention, like I say, it's often not so much about money. It tends to come down to, the environment in which people are working, their relationships with other physicians in the community, with the other members of the healthcare team in the hospital. Those are sort of powerful things encouraging recruitment, and then as I say, or retention. And then, as I say, often the factors that cause people to leave are more based around family circumstances, opportunities for family members elsewhere, and all the rest. In terms of patients struggling to get appointments, I guess what I'd say there is that people are welcome to phone in or to walk into the Port McNeill Primary Care Center. I don't know if people realize that's an option available daily, because I know sometimes if people have a preferred practitioner that they want to get in and see, there may be a wait time there, but certainly in terms of walk-ins and same-day appointments, those are available at the Port McNeill Primary Care Center.
I think there might be a better way to let people know that, because I have told that to people and I've driven by and seen a sign, but I don't think a lot of people know that. So just want to put that out there for a way to get that information to the public. Sorry, go ahead, Councillor Downey.
Thank you. What initiatives are in place to retain existing healthcare workers and to support those workers who are feeling overwhelmed and burnt out?
Yeah, thank you so much for that question. I think we've covered a lot of the various initiatives that we have in place around stay conversations, being able to bring in additional providers, different type of providers, more leadership, more education supports. We absolutely recommend individuals who are working within our system or our partners that are feeling burnt out or feeling low to be able to talk to their leader. One of the pillars within our strategy within Island Health is really to be able to have approachable leaders, and for us to be able to have leaders that are well supported by our executive as well. So, it really is there to be able to support our frontline staff. And I think I'll leave it at that, because we've covered a lot of other items that we have around retention and recruitment efforts.
I think number 20 is Councillor Mitchell.
Is Island Health working with their current medical practitioners to ensure our community has quality medical care?
Yes,
That's been answered pretty thoroughly too.
Well, maybe there's a couple of pieces I can add. Dr. Nicole Bennett-Boutlier, who's not able to join us tonight, she's the medical director for Mount Waddington. I have weekly check-in calls with her. Perhaps more importantly, though, she has regular calls with physicians in the community and physicians who are interested in practicing in the community. We have a couple of new physicians scheduled to join the practice in Port McNeill this summer. I know she's been doing extensive consultations with them and answering all their questions and really making herself available to them. Dr. Shannon Wong in Port Hardy is fulfilling a similar role there. She's in close contact with Dr. Nicole Bennett-Boutlier. So absolutely, we're trying to make sure that the practitioners feel supported in terms of both, sort of what's needed within the Mount Waddington sites, and then also in terms of their connections with larger centers. I was on a care conference earlier this week about a patient, inpatient in Port McNeill, who required sort of consultative services at Comox and stuff, and how do we enable that to happen? Because again, given all the challenges in the system at the moment, it's not always easy for the doc who's got a full clinic and stuff to sort through some of the transfer issues and all the rest as they come up. And so certainly Nicole is involved heavily in those discussions.
I'm going to take us to communications. So to date, we've received service updates through the RCMP, through Island Health, and the Town of Port McNeill Facebook pages, which are then shared around town. That's the current communication strategy that's in place. Do you have any plans for a more comprehensive strategy to share pertinent and timely information? Could digital signage be placed at each of the hospitals?
That's mine. I'm sorry. I couldn't get the comment box out of the way there. Yeah, so, we're very thankful to the supports that we received from community leaders around being able to share information when we had our 2 emergency department closure events. We try to share that information ourselves through the mechanisms that we have. And we believe that we also have had a quite a positive impact in being able to reach a large number of individuals through those means, through our news feed, through our public service announcements, and also for the way that we're able to share this information on social media. So again, we really, when those events happen, we really want to be able to reach as many people as possible. So we need support from the community to be able to do that appropriately and with good effect. When it comes to digital signage for our hospitals, we definitely are looking at enhancing the signage that we have for our 2 clinics that we have operating and some of the signage that we have currently available. It won't be around like the hospital is closed kind of piece or around the signage, but it's really going to be focused on helping create a more welcoming and safe space for individuals to be able to come and receive care, and signages that's a little bit more clear around when to access and what type of hours that we have within our clinics and those pieces. So when it comes to signage, we have a plan to improve our signage. When it comes to notifying through signage of ER closure, we have our postings that we place on the door, and we always have staff within our hospital sites because of our inpatients. But really, we're looking for partnership to be able to get that message out to everyone.
So we put it on our digital sign then? Is that how we manage that?
Yes, I guess you could, right? I'm trying to picture the sign in my mind. But yeah, any type of support that we can receive in terms of being able to provide that information for the public is absolutely helpful.
So just for an example, when the ER was closed, it was a major soccer tournament weekend, all ages. And that was a topic of discussion on the sidelines, is that the ER was closed because typically somebody's injured. And so, for you think maybe that's not necessary, but for parents with kids playing, if they know the ER is closed and they heard about it randomly, they all were planning their strategy as to what they would do if services were needed. They were reasoning amongst themselves, but they didn't all get the information at the same time or on a timely basis. So that's why I'm not trying to be silly here, but signage just to inform the public to say, ER is closed from these hours to here, lets everybody know to make other plans, right? So that's where that's coming
yes,
from.
Sorry,
it's providing a safe community, right? That's what we're looking for.
Yeah, absolutely. Yeah, sorry. And my response was, are we going to develop digital signage for the purpose to describe that it's closed? And that's not something that we've thought about, but we can definitely take that back and incorporate that as part of our strategic work around our signage enhancements.
Okay, on to BC Ambulance. Another question here, acknowledging this isn't in your wheelhouse, although we do have, I believe it's Matt from the ambulance service here. What, if anything, can be done to employ and retain more BC Ambulance paramedics on the North Island so that the current ones don't get burnt out due to lack of staff?
Yeah, thanks for that, Councillor Cole. So it's already been mentioned a couple of times that a couple of the huge challenges on the North Island have to do with affordable housing and availability of rentals. But one of the other challenges we're facing is a limited number of locals that have a desire to take on this type of work. And so it does lead to pressures with recruiting locally. But as an organization as a whole, BC Ambulance has really ramped up the provincial and national advertising with a proper media campaign. And then in the short term, there's a bunch of temporary staffing measures underway in the areas surrounding Port McNeill, which the intent is to relieve some of the pressure that is put on the Port McNeill paramedics to respond to those outlying communities when they're short-staffed. So that's in place and should come into play within the next couple of weeks. The local recruiting, it's more of a struggle there. To date, it's been more of a grassroots thing where it's word of mouth, paramedics talking to their friends, unit chiefs talking to the towns and stuff like that. And it's a really slow process, which has a pile of challenges associated with it. Nonetheless, we have managed to put a emergency medical responder course in place in Port McNeill for the month of July, and still seeking a bunch more recruits to get in there. But with any luck, that is the start of a more robust recruiting strategy, in that hopefully that is the first of a few courses that'll be held during the year in the area, so that people don't have to travel to obtain the training to work for the ambulance service. So there is a bunch of initiatives in place. Not any one of them is going to work on its own, and things are ramping up more and more and more as the government recognizes that this is not an issue that is going to have a short-term fix. And the last thing that the ambulance service is doing is, over the next couple of weeks, they are actually standing up an emergency coordination center having to do with staffing and recruitment in the province. So over the summer, that should see some fairly decent efforts in that regard. Thank you.
Thank you.
Thanks for that, Nat. If you can let us know, especially if there's spots available, we can certainly get the word out, and we might even know some people who would be suited to that kind of work. So it'd appreciate if we could get that information. We're at the last question, and then I'm going to turn it over to Angela, because I think she might have one or two final questions for us that have come up. So long-term planning, we have the regional district hospital, which does capital planning. But this specific question says, what information on long-term planning and projections of service and infrastructure do you have for our community? And is it possible that we could see a budget plan, for a forecast plan for 5, 10, 20 years out, so that we could understand how we can better prepare our community for the healthcare service level that's anticipated?
Yeah, no, thanks very much. So Island Health updates and submits its health plan to the Ministry of Health every year. And we also wait from the Ministry of Health for their budget documents and their guidance documents to us as a health authority, through their mandate letters. Our health plan includes an overview of Island Health's key accomplishments, challenges, and plans for the next 3 years, with a focus on the current fiscal year. For us to support strategic planning and community engagement, we create these community profiles, and I believe those community profiles are posted within our website, and they're for areas across Vancouver Island. These profiles describe community health, including many factors that contribute to health or detract from health, such as economic status, education, housing, all those determinants of health that really help identify how to structure the health and social system. Links to these profiles can be shared. We can put them in the chat and share them with everybody. So when it comes to long range planning and forecasting, I think it's less about the budget forecasting, but more about us being able to come together and look at what the demographics are of the population, where the population demographics are projected to be over time, to be able to break down those demographics within certain quadrants or certain types of individuals. We know that the first baby boomers are hitting 75 years now. And over the next 10 years, we're going to have a big influx of baby boomers that are going to be looking for services within the health system and the social system. So it's about us being able to work together as a community to be able to develop our plans for how we're going to be able to serve the growing population, but also the growing seniors population and the population with higher needs as well. And so that we can better serve that population within the community. So it's less about 5, 10, 20-year budget cycles, but more about how we are able to structure our services and work together strategically to be able to build those services to best support the individuals within the community that we're projecting out over the next number of years.
Maybe I'll just add that, I mean, this is a bit of a technical question to answer, but I think what I want to say is, I hope we've provided enough evidence and opportunity here to leave the community recognizing that we're actually trying to invest in our services in the region. While we're not succeeding in the way we would like to around recruitment, we know the population growth north of the Malahat is where the island is growing exponentially. So there are plans within Island Health, obviously, to budget accordingly due to all of the factors that Max just laid out. But really for this forum, I think it's important just to reiterate, there are no plans to close the hospitals. We are attempting to hire more people into the hospitals so we don't end up in a position of diversion or having to have closures of our ERs. I really hope that's a message that our community can take away. And we look for opportunities to partner on the challenging pieces around rental, housing. And I think Nat might have just spoke about it too, but word of mouth is increasingly important when resources become scarce. So we want to make this region a very attractive place to live and work.
Thank you. Angela, was there something you wanted to bring up that we hadn't addressed through the chat box and answered?
Certainly. Thank you, Mayor Wickstrom. So one question directly relates to, James, what you just commented on, and relates to a point raised by Councillor Downey a few moments ago, and that is around planning and closures. And one question that came in was, will there be overnight closures planned to potentially consolidate staffing and thereby reduce diversions?
Yeah, I can jump in on that. Sorry, I'm looking at the Q&A and it covers up my unmute button. So my apologies for the continuous delay on that. So as I mentioned earlier in our I think it was in the presentation, we definitely hold a responsibility to ensure that we are providing safe services for individuals within the Mount Waddington area. Our jobs are also to be able to look at various scenarios and plan for those scenarios if there was a dramatic decrease in staffing in the short term, or projected decrease in staffing due to people retiring or leaving their positions or moving away from Mount Waddington. And as we identify various scenarios, we look at our ability to plan around those scenarios to be able to still optimize the services that are available for people and ensure that we're providing high quality service. And we're also protecting our staff and not burdening them and providing all the supports that we possibly need. We are not at the moment at all looking at scheduling long-term diversions for any of our sites. What we're finding is that when these short-term scenarios, when we're faced with these short-term scenarios due to staffing, what we need to do, it's really challenging scenarios for us to be able to build various algorithms to kind of just say, oh, this is going to follow this pipeline and that's what we're going to do. We really need to be able to assess the type of staff that we do have available, the physicians that we have available, our support individuals that we have available, working with Nat and his team, and being able to identify what the appropriate plans are at those times to be able to support the right type of care to be able to be provided and the best services available. So it's dynamic. It's very challenging, and it's very based on the scenarios, including the individuals that we're providing care for within the hospital and their acuity, how we strategize our responses to being able to provide safe services for individuals.
Okay, thank you, Max. So that was potentially a maybe to that question as a potential strategy point. Another question that came in was, and was answered in the comments, was, does Island Health have employees at home and not working because they're not vaccinated? And in the comments, we had the reply that those individuals who choose not to vaccinate are not eligible for employment within Island Health. So that summarizes that.
Can I just add a little piece to that?
By all means, Ian.
Yeah, because again, I think sometimes people are unsure of who's got sort of jurisdiction over what. And so, for instance, in vaccination, because that was under the public health orders, there was basically a message that went out from the College of Physicians and Surgeons of BC saying, you have to get vaccinated. We followed the public health orders, which say that you can't be working in an Island Health facility or under contract for Island Health if you're not vaccinated. But really, those decisions are made provincially through the medical health officer's office, and we as stewards of the health system have to follow those directives.
Great, thank you. There's very little else by way of questions. There's some comments around a bit of frustration over the gaps with BC Ambulance that we see when diversions are called on, how people feel vulnerable in community. That was one notation, and the other was frustration being expressed by nurses. I'm willing to work in a community whose applications were lost in administration. So some of them are expressing frustrations in the private comments to hear that more administration is being hired to figure out how to fix administration. They feel a little bit left in the lurch over that, but of course we're going to work through that. We heard that we're going to work through that process. So aside from that, I don't see anything else that's come in. So thank you very much for that.
Okay, great. Well, thank you very much for this evening. I hope that the public has had many of their questions answered, that this will alleviate some of the fears and concerns, and that moving forward, we can all work together towards solutions to these problems. Leslie, Dean, Nat, Ian, Max, and James, thank you so much for joining us this evening. We really, really appreciate that you made the time to do this. So on behalf of council, I thank you. To my fellow council members as well, thank you very much for attending. And Angela, finally, and the Mount Waddington Health Network, just wanted to give you a big shout out to helping us moderate and for setting this up today. It's greatly appreciated. So thank you very much, everybody, and have a wonderful evening.
Thanks, everyone.
Bye.
Thank you all for your time.
Good night.